So good morning friends. In this video we'll discuss about the parasitology important points and so before starting the session I'm saying this is I'll be covering only the important points that is usually asked in the examination, particularly for the MRB exams. Okay, so first we start with the amoeba. Okay, so first it is an entamoeba histolytica. Okay, so always remember, if you're taking any parasite, first you want to know what is an habitat, second what is the morphological forms, third what is the clinical features and how you will diagnose, and finally the treatment. So if you are reading all the parasite in this order, you will not miss any points. Okay, and in exams also the questions won't be that much deeper, so it will be very superficial. So like entamoeba histolytica usually resides in small intestine, large intestine, and it can be like a stomach. So the options will be very clear, and so that it won't be that much deeper or that much elaborate. Okay, so you can make out the diagnosis very easily. So first here, so entamoeba histolytica usually resides in large intestine. Okay, so coming for morphological forms, there is a tropozoid form and there is an quadrinucleate cyst, and you want to know which is an infective form. And for entamoeba, it is a mature quadrinucleate cyst. So, and they can ask this also. Okay, so which is an infective form for entamoeba, like that. Okay, so next it is in clinical features. So first it is usually the patient will be very asymptomatic. Okay, so second they will be present with colitis, that is usually this is an important term you want to remember, that is a flask shaped ulcer, and it is usually present in the ileocecal junction. Okay, so most common site is ileocecal junction, and the patient will be presenting with amoebic dysentery. In that, if you are examining, you can look for charcoal laden crystals. So again friends, so charcoal laden crystal is not only present in entamoeba, and there are many parasites. So again I am having some of the parasitology mnemonics, and I will be giving a description, and kindly go through that. Okay, and there is a topic like test in parasitology, so again I will be posting it in the description, and go through that also. So coming for next, it is a liver abscess. So friends, here you want to remember, one is a flag shaped ulcer, second it is an anchovy sauce pus, that is it is usually like chocolate brown pus, and here the most common region is posterior surface of the right lobe of the liver, whereas the colitis, that is a flag shaped ulcer, is present in the ileocecal junction, whereas liver abscess, it is present in the right lobe of the liver, that is on posterior surface. These two are the important questions that can be asked. Okay, so how you will diagnose this? One, it is in stool examination. You can make out any disease, and second it is in zymodim analysis. So this is a new term, and it is mainly to differentiate between the pathogenic and non-pathogenic amoeba. Okay, so if you remember, that point is enough. The zymodim analysis is for differentiating the toxic and non-toxic strains of the amoeba. Okay, so coming for treatment, you always it is a drug of choices, metronidazole, and for carriers you can give the paramomycin. Okay, so I think there is an so I think in this need they have asked about some patient got admitted with dysentery and how will you treat this. The option they have given is metronidazole. Okay, so always remember, for amoebiasis, it is a drug of choices, metronidazole. Okay, so these are the points you want to remember for entamoeba histolytica. So coming for next, it is in you can differentiate this two because they will be like similar only. Okay, so first Trichomonas vaginalis and Giardia lambia. So friends, now you want to remember it is an genital flagellate. Okay, Trichomonas, it is a genital flagellate. whereas Giardia lamblia, it is present in the small intestine. So it is an intestinal flagellate. Okay. So coming for the morphological form, Trichomonas has only tropozoid. There is no cystic stage. You can remember like T for T. Okay. So coming for Giardia lamblia, it has a tropozoid and cyst form. So here the infective form is tropozoid and here it is in cyst. Habitat, I told you it is a vaginal flagellate, it is an intestinal flagellate. So it is usually resides in the small intestine. So next coming for clinical features, it usually presents with, so Trichomonas usually presents with like a vaginal discharge will be there, foul smelling discharge, and there is a peculiar term that is called as in strawberry vagina, that is in colpitis macularis. And here coming for Giardia lamblia, it is in diarrhea, malabsorption and steatorium. So friends, again you want to remember the another point. Suppose if they have given a history of like steatoria or malabsorption and the options are related to parasitology, the most common organism it is in Giardia lamblia, which is usually associated with this malabsorption and the steatoria. Okay. So again, the another point, it is usually associated with the severe SCID, that is a severe combined immunodeficiency. Okay, sometimes if they have given that word, okay, so you can mark it as Giardia lamblia. And coming for so diagnosis for Trichomonas, since it is present in the vagina, so you can do the so bit more for vaginal discharge and also the urine examination. And here there is a special motility, okay, that is called as an falling leaf motility. And again for Trichomonas there is a jerky motility. Okay, so here it is in falling leaf and here it is in jerky motility. And treatment, so both you can give it in metronidazole. Okay. So friends, again here it is an important test for Giardia lamblia. It is in lamblia. Okay. So here it important that is called as an anti-road test or the string test. In this video I didn't cover any test because I have posted a separate topic like test in parasitology. In that I have mentioned all the tests, okay, used for diagnosis of the parasite. So you can go through that for the clear idea. So okay friends, and again you must not miss any point because I have collected only an important points only. So you must not leave any single point from this video. Okay, so next chapter it is in free living amoeba. Okay, so in this we will be dealing with three species. So one is Neglidia fowleri, Acanthamoeba and Balamuttia. So here first remember what is a morphological form. You can remember like for all the three species it is in cyst and the tropozoid. Okay, so only coming for infective form, Neglidia fowleri, it has an tropozoid. In that there is an amoeboid form and the flagellated form. In this amoeboid form it is an infective and here it is in cyst or the tropozoid, whatever can be. Next coming for here you want to remember the clinical features. Okay, so here first Neglidia fowleri usually presents with PAM, that is in primary amoebic meningoencephalitis, whereas Acanthamoeba and Balamuttia or granulomatous amoebic meningoencephalitis. So friends, in Acanthamoeba you want to remember about the keratitis. I think you know right now because always Acanthamoeba is associated with keratitis. And history there will be given like there is a patient using a contact lens and he developed a corneal redness or conjunctival redness and there is an excessive discharge. Okay, so if they are given a contact lens user, if it is an like bacteria, it is usually associated with the Pseudomonas. If it is a parasite, it is an Acanthamoeba. Okay, so you can close your eyes and you can mark it as an Acanthamoeba. So how will you diagnose this? So friends, here remember this Neglidia and Acanthamoeba, it is only diagnosis. You can see only the tropozoids in the CSF, whereas in Balamuttia you can make out the both tropozoids and cyst. So coming for treatment, the Acanthamoeba, Neglidia fowleri is an amphotericin B and Acanthamoeba again I have mentioned no mostly there is a no treatment. But if the option is have been given like amphotericin B, you can mark it up. Okay, so Sagit Balamte, there is no treatment. Okay, so friends, you want to remember here the clinical features, because, and I told another point, that is an what is it, amoebic keratitis. It is usually associated with a acanthamoeba species. Okay, the friend, I think so we have completed about the amoeba, free living amoeba, and the intestinal flagellates and the genital flagellates. So next, it is in hemoflagellates. Okay, so in hemoflagellates we'll be dealing with leishmania and the trypanosoma. Okay, so first it is an okay friends, so leishmania and trypanosoma. So in leishmania there is you want to remember first what is a morphological form. So again remember here, in leishmania and trypanosoma, that morphological forms are promastigote, amastigote, but whereas in trypanosoma it is a trypomastigote. Okay, so here the infective form is paramastigote, whereas here it is in trypomastigote. Here next the vector, here it is in sandfly, here it is in reduvid bug, and for brucey it is in sepsi fly. Friends, these are very very important points. Okay, so next, what are the clinical features? Okay, let us see this. And coming for what is it, so cutaneous leishmaniasis. So it is caused by Leishmania tropica. Okay, that is called as an oriental sore or Bohat boil or Delhi button. There are many terms which have been given for this. And mucocutaneous leishmaniasis causes an, that is an espundia, which is usually caused by Leishmania brasiliensis. And again, you know this Kala Azar, that is a famous term. It is caused by Leishmania donovani. And here you want to remember about the Donovan bodies. And again, the Kala Azar usually presents with a triad, that is, it has an what is that, pancytopenia, and it will be presenting with an massive splenomegaly. Okay, so you want to remember these 2 points. And coming for Trypanosoma cruzi, it causes in Chagas disease. So always remember, Chagas disease is characterized by everything will be mega. Okay, that is a mega esophagus, mega colon, and Romanocine, it is nothing but it is an unilateral edema of the eyes. So here Trypanosoma brucei causes some sleeping sickness, and there is a peculiar sign called as a winter bottom sign. That is nothing but it is an enlargement of the posterior cervical lymph nodes. Okay, so coming for lab diagnosis, always remember the peripheral blood examination. In this you can first Leishmania, I told already, you can look out for the Donovan bodies, and that's a important medium, that is an N, that is a Nove, McNeil and Nicol. They can ask this also, what is the media used for Leishmania? Okay, so again I am saying in MRB the questions will be very straightforward, and it will be very single line. Okay, so the thing is you must not miss any points. Next, they want to ask what is the basic for this and how there is a fever will be occurring in the patient. There won't be that much complicated questions. So again here the test is Napier aldehyde test, and as usual you know for everything it is an ELISA. But you want to remember these 2 tests, that is medium NNN and Napier aldehyde test. So whereas cruzi and brucei you can look for the trypomastigotes. Okay, so friends, again here the treatment you want to know about for Leishmania, it is an amphotericin and paramomycin, pentamidine and miltefosine. So here this paramomycin we have been used again in the carriers of the entamoeba, and Trypanosoma cruzi, this is nothing but it is in benzinidazole and nifurtimox, whereas brucei, suramine and pentamidine. So just remember the names, that is more than enough. Okay, so this completes the hemoflagellates. So next, it is in coccidian parasites. So in coccidian parasites we'll be dealing with Toxoplasma and Cryptosporidium, Isospora and the Cyclospora. Okay, so first, so Cryptosporidium, Cyclospora and Isospora. So here the infective form, it is an sporulated oocyst for all the 3 species. So next it is in the size is important, friends, here. Okay, so just remember like 6, 12 and 24. So whatever you can. So it is easy to remember like 6, 12, 24. So just 6, if you double it 12, and if we double it 24. Okay, so the order must be here, crypto, cyclo and iso. So next, this is an important, that is an acid fast. So here crypto and iso are uniformly acid fast, whereas cyclosporo it is an variable acid fast. So treatment is important. This two will be having cyclo and iso, it is in cotrimoxazole, whereas cryptosporidium it is in nitazoxanide. Okay, so we want to remember the infective form, and the size is important, and the treatment is important in this condition. So here, so just it is to completion sake I'm saying. So this will be having a cyst wall, and there will be a single cyst which contains a spore, that is a 4 sporozoids, whereas here it will be having a 2 sporocysts which will be containing a 2 sporozoids, whereas isospora will be having a 2 sporos, that is a 2 sporocysts, and it will be containing a 4 topozoids. Okay, so just remember this diagram, it's more than enough, but I think they won't ask that much detail. Just remember a treatment and what is the size and what is about the acid fastness. Okay, so next, this is an important, that is in Toxoplasma gondii. See friends, in this there are 3 morphological forms. One is polluted oocyst, one is stachyzoids, and there it is in bradyzoids. Okay, so here the infective form is all the 3 stages are infectious. So here the definitive host, always remember toxoplasmosis means it is in cat. Okay, so intermediate host or man and the other mammals. So coming for ingestion, which is so transmission is by ingestion of the sporulated oocyst, usually from the contaminated soil, food or the water. So coming for the congenital toxoplasmosis, so here the most common manifestation is chorioretinitis. It will be severe in first trimester, and as you know, everything, all the infections are usually transmitted only at the 3rd trimester, and you can remember like 3C and 2M. Chorioretinitis, cerebral calcification and the convulsion. So 2M is microcephaly and mental retardation. So most common manifestation, I already told, it's in chorioretinitis, and the drug of choice is usually it is in cotrimoxazole, but in pregnancy you can give this pyramycin. Okay, so again there has been a question in the NEET PG, like it is in previous year question. A pregnant female who's a known case of toxoplasmosis, and she was non-compliant about taking the drug. Okay, she didn't take pyramycin, so the baby developed an intracerebral calcification. So what will be the probable diagnosis? Okay, it is nothing but it is in congenital toxoplasmosis. So some clues will be there. Okay, just you wanted to take it out, or you wanted to know that, that's it.